Yes, I just want to present my initial experience with the fovea sparing ILM peeling in the vitrectomy for proliferative vascular diseases. So ILM peeling in vitrectomy for proliferative vascular diseases is practiced mostly to remove the macular folds and reduce the chances of reproliferation. However, there are problems like foveal thinning, foveal drag towards the disc, and paracentral holes. So they have been highlighted in many studies. So, foveal sparing ILM peeling is recommended in myopic foveosis cases in many by many authors. So, can we apply the same in vascular proliferative diseases? So, we did an retrospective analysis with inclusion criteria of cases undergoing vitrectomy for proliferative diseases between February 22 and June 22. All those cases underwent fovea sparing ILM peeling were included. The follow-up was less than 3 months was excluded. Cases with combined RDs were excluded. So ILM peeling technique involved curvilinear peeling, a U-turn or a circle back to avoid the foveal peeling, and doing the flap and trim. And most of the cases were done, all of the cases rather were done by the combination of two or more of these techniques. We analyze the demographic data, analyze the OCT images pertaining the macular thickness and foveal contour, and compared the final best corrected visual acuity at 3 months. So there are 8 cases were included, 5 males, 3 females. Mean age was 46 years. The diagnosis was PDR is most common, BRV, and one case was EELS. So we found 4 types of contours. One was well-maintained contour. One was wavy contour but well-maintained foveal depression, persistent macular edema in one case, and moderate foveal thinning. So well-maintained contour was seen in 3 cases, foveal thinning was seen in 3 cases, and macular edema was seen in 1 case. Final visual acuity is presented. Majority of the cases lie between 618 to 636. So subjective observations where the visual acuity is better preserved than generally observed with conventional cases. Foveal contour was generally well maintained, better than the observed with full ILM peelings. Problem with foveal thinning and persistent macular are still seen in fovea sparing peeling, and no specific surgical technique related complication was encountered. Thus, the fovea sparing ILM peeling was generally safe as a technique. Foveal contour was maintained in many other cases. We need larger studies, larger series with comparative study to actually go ahead with this study. Thank you.
Nice presentation, Dr. Atul. What is your hypothesis?
The hypothesis is the fovea ILM is there to maintain the integrity of the fovea. The absence of ILM may lead to the foveal thinning or dragging of the foveal area. So if you let's say hypothesis is the same as what is there in myopic foveosis. It's the same hypothesis applied here.
What was the indication for ILM peeling? Like routinely you peeled ILM in
all cases having a macular folds basically, which are not removed by just simple ERM peelings.
I know, but in your cases macular hole was not there, right?
No.
So that's what is the indication for ILM peeling is what I'm asking.
Is remove the macular folds which are not removed by the removal of epiretinal membrane alone.
Okay, but the case which you showed did not have macular fold. That was a very well stained ILM, but there was not even no ER.
There are some ILM folds there. Folds were there, not.
Okay, because ideally, if you want to prove that inverse peeling or the foveal peeling helps, then you need to have the study design has to be like in one group you have to peel.
Yes, agree.
Another group.
Agreed. That's what I'm telling you. It's just an initial experience. It's not a full-fledged study.
Anyways, nice presentation.
Yeah, nice presentation.
Question. This session.